Hi everyone, this is your Social and Behavioral Sciences, Health Promotion, Health Education, a quick summary for chapters 6 through 9. We're actually going to be the next class for fall 2, or depending when you're taking the class, is Social and Behavioral Determinants of Health. So we'll dig even deeper to this section of public health. But just to give you an overview and a foundation, this is a summary of those 4 chapters. Again, a summary of chapter 6 through chapter 9, focusing on social and behavioral sciences, health promotion, and health education. The major focus in public health, there are 3 types of prevention. When we think about primary prevention, we're thinking about preventing a disease for anyone. So there are no risk factors yet. We're just doing health-related behaviors to prevent a disease from occurring. Now when we start to think about secondary prevention, secondary prevention includes things like screening, because now the intent is early detection. Usually when we think about secondary prevention too, there might be some risk already involved. So secondary, there's some risk, and we're trying to prevent disease from happening with the idea that, there's some type of risk or exposure involved. Tertiary prevention refers to health-related behaviors after a disease or injury has already occurred. So this is when you're trying to reduce complications or trying to manage the complication or condition in general. So if we were thinking about obesity work, obesity prevention, primary prevention would be doing a program on healthy eating and physical activity for, let's say, for targeting kids in all schools. So every single child is involved in this intervention to eat healthy, to get more physical activity, because we want to prevent kids from being overweight or obese, especially as adults. But of course, when you're targeting the whole population of kids within a school, that can include, everyone, kids who are normal weight, kids who are overweight, but that's still primary prevention because it's not specifically targeted towards anyone at risk. It's very general. So again, in an example where we're targeting kids and using the school setting, targeting all kids to prevent, overweight or obesity, that's a type of primary prevention. Secondary prevention might be an example of a child is already, overweight, or they have some type of risk. So one example in childhood obesity is doing healthy eating and physical activity among children who are overweight. So now we're kind of specifying where the risk is. So we don't want them to continue to be overweight or obese going into adulthood. But this is secondary prevention. So it's sort of targeting kids who are already at risk. And then tertiary would be, children who are already past being overweight, but in the obese category. I don't think children, you don't necessarily categorize them as obese, but for the purposes of this example, let's say a child was obese, that would be tertiary because the disease or the injury, that has already occurred. So the health condition of obesity has already occurred, so this is tertiary prevention. How can we get them back to normal weight? So primary prevention, you're trying to prevent a disease from ever occurring, and this is more wide within a community, within a nation, within a specific group. Secondary prevention, there's already some type of risk that you're trying to catch, and this includes screening, breast cancer screening. It includes colonoscopies, any type of screening or preventative behavior. Again, with the idea of thinking that there's already some type of risk involved. And then tertiary is, okay, the health-related behavior or condition is already occurring, and so we're trying to manage it, reverse it, and reduce complications. We talked a little bit about the socio-ecological model, so again, just to reiterate, starting from the most inner unit, yourself, that's at the intrapersonal level, so that those are things like genetics, your particular behaviors, psychosocial characteristics, other sociodemographics. That's you. That's the interpersonal level. Or if we're talking about a participant, that's them personally. Interpersonal level, now we're starting to get into relationships, so more than one person. It could be your friends network, it can be family, it can be your community, it can be cultural. It's interpersonal, and usually when I think about that, I think more than one person having to do with social networks. Organizational level, you can think about work environment, again, kind of even the community environment, and a lot of times policies within an organization also influence behavior. Community level itself has more to do with laws, such as alcohol laws, community norms, even the way the community might look. And then physical environment. So some type of outside pollution, public policy, so state and federal policies and law. So those are things. So all of these levels of influence have an impact on behaviors and have an impact on health outcomes, and they don't work so much independently than they do work together. And the more levels of influence that you can tackle in an intervention, the better. So here's some of those, couple of those points. So there are many influences to health behaviors, both at the micro, so thinking the individual, to macro level, all the way up to policy. The levels within, as I mentioned, work together, they interact, they are iterative. So they're not independent of each other. And again, when designing public health or other community interventions and programs, using micro to macro levels of influence have the largest impact. And when we do these models, similar to what I was starting to talk about with theories, they do have to be very specific to a behavior that you're doing. So when you talk about theory, you're going to be specific as you develop your conceptual model, but the same goes for thinking about socio-ecological models. How do they influence our particular behavior at these different levels? So as the slide says, to tie this together, it can be said that the goals and objectives of public health intervention are often focused on all of these types of interventions, so primary, secondary, tertiary. Interventions themselves can occur at one or more of the ecological model. So you can have an individual-focused intervention, you can have a community-level intervention, or maybe you have an intervention that works with individuals, social networks. So maybe it's a family intervention and it works within the community or environment. So you have an intervention, but it includes multiple levels. So you can tackle one level or you can tackle multiple. But the ultimate goal of interventions is to enhance quality of life, improve health outcomes, and reduce risk for specific health conditions. So that's an overview of thinking about the different types of interventions: primary, secondary, tertiary, and then also again thinking about the socio-ecological model for which to frame how and when you do those interventions. So chapter 7, this one is about planning health education and health promotion interventions. So here it says, imagine you are a community or public health worker, or maybe someone who's just interested in implementing a health-related intervention. You know, what do you do? How do you start? How do you know if it worked? There's been a lot of work invested in elements when it comes to planning models. So some of the elements when we think about planning models include planning itself, implementation of an intervention, and also evaluation. Now in class, I made sure to emphasize that planning models are very different than behavior change theories. And you can kind of see that here, that when we're talking about planning models, it is really about how do you put together an intervention? How do you plan for it? What are the aspects of implementation? Then, what should you consider for evaluation? So it really says nothing about, how do you change behavior and what is the curriculum, we can say, for the actual intervention. It's more so planning, how do you conduct it, how do you evaluate it. So there's some models done to formalize this process. And here I'm just going to go over the main one you should know. And again, we're going to go deeper into these planning models and theories as we get into the larger course of social and behavioral science and determinants of health. But the one planning model that you should really know is precede, proceed. It is one of the most well-known and used planning models in public health. And precede stands for predisposing, reinforcing, and enabling constructs. Think of them like factors or risk factors in educational or ecological diagnosis and evaluation. So this is kind of precede, such a nice acronym. So it's kind of the planning stage. And then proceed, sort of towards the end, is, policy, regulation, organizational construct, again, in educational and environmental development. So again, that same overall goal, improving quality of life in a defined community. But again, precede, proceed model is a planning model on how to implement a project. It contains 8 steps. It goes into more detail in the book, but the first 4 steps make up precede. And the goal is to collect information, and it helps in decision making about what factors to intervene on. So thinking about what are the risk factors, how should we think about the elements of the intervention. The final 4 steps make up proceed, and that aim is more to strategically implement effective interventions and or modify important determinants of health. So here it says to ensure such interventions are implemented effectively. The final 4 steps also outline an evaluation strategy. So really it's about precede, how do you decide on what to do? Proceed is how do you do it and how do you evaluate it? It'll be really nice to go through the 8 steps as you read your textbook and really understand those elements. Now chapter 8, we kind of went over this in class. I created supplemental class slides on theory, and I know we did it pretty quickly, but those slides explain a little bit better, in my point of view, health belief model, theory of reasoned action, and theory of planned behavior, stages of change from the trans theoretical model, and also social cognitive theory. But again, your book is really helpful, so I would make sure to read those, but also definitely look at the supplemental slides that I posted in this module. The other theory that I didn't include in that slide, but I really want to make sure you guys pay attention to and know, is diffusion of innovation. Now, there are a lot of other constructs, but the one that I think about the most is time. And when you're creating a new intervention, diffusion of innovations is really helpful in thinking about, who's going to participate or uptake in your intervention. A really easy example is like a health app. So who is going to be the innovators of this health app? These are the very first people, not necessarily who are using it, maybe those who are the first one or two people, those who are kind of inventing it, creating it. And then you have your early adopters. So those who are willing to try a new technology. And often those are your leaders in some type of voice. They could be peer leaders, community leaders. Oftentimes these are your early adopters. And then you get the early majority. So then you get the majority of people who are interested and would use it. A lot of times they hear about it from early adopters. And then you get that next big chunk of people who are using, in this example, like a health app. And then you have the late majority and the laggards. So I used to think of myself, for example, as kind of like a late. I like to watch technology and see what it does before I hop on the bandwagon. So I would consider myself maybe somewhere between late majority and laggard. So kind of waiting a little bit. But it's really helpful to think about these adopter categories. Let's say if you're doing a community intervention, you want to figure out who are your early adopters. Maybe they are community leaders. Maybe you involve them in the design process itself, so they also kind of serve as innovators. But that first, about 15%, these are your leaders, the ones who are going to talk about it, maybe the ones who are actually giving the intervention. And then you have early majority, so other people who are joining, and then maybe those who are still kind of looking to see what's going on and then deciding later. And then also related to time is rate of adoption, so how fast innovation occurs over time. So diffusion of innovation, like I said, there's a few other constructs to consider that you can read about, but it's always been fascinating to me to think about how people adopt and where they kind of align. So think about yourself, if a new technology comes out, or let's say you see an exercise program that's being offered here on campus, are you an early adopter? Are you going to jump on that, fairly quickly and tell everyone about it? Are you going to join, when most other people join, or maybe even a little bit later? Or are you a little skeptical and not sure, and maybe don't decide to join until much later? So it has a lot of implications for when we think about the design of interventions. This last chapter, methods in health education and promotion, kind of goes over the definition of an intervention again. So an intervention can be defined as a systematic set of processes designed to produce a desired outcome or effect. So in our field, oftentimes interventions are called programs, and I know when I've talked about it, I have intertwined, interventions and programs. But either way, they are designed to change behavior, reduce or lower risk, promote health. So we can think of, interventions or programs related to smoking, drinking, physical activity, texting and driving. We've seen some of those interventions lately. But I will say, on the note of sort of the verbiage around interventions versus programs, sometimes I like to think of interventions as intervention studies, So very much a part of research, understanding does this work or not. And other times I like to think of programs as the result of having done the research to say, hey, this intervention works, let's now develop it into an actual program. So again, sometimes those words are used interchangeably, intervention or program. But another way to look at it as well as intervention, I tend to relate it to intervention studies and research, and programs could be more implemented in practice. And there are a lot of programs that exist that are not based in evidence. So definitely I hope that, especially in public health, when we do implement and think about programs, that they are based in evidence from previous intervention studies. So that's how I kind of use the words when I try to use the terms properly. But again, when we're thinking of, how do we come up with health education and promotion, activities, the first thing is to think about is, how do people learn? And I think I talked about this in class, but they are visual learners, so really just looking at things, so flow charts, pictures. And then you have those who are auditory, who like, for example, this voiceover. Sometimes it's easier, even if you're reading and seeing the slide, to actually listen to someone explain and discuss the information. And then you have reading, writing learners, so those who learn by reading or taking notes, transcribing. And then you have the kinesthetic learners, so learning by actually simulating how it might be done or in practice, kind of hands-on learning. And the reason it's nice to know about these 4 different styles or these primary ways to learn, and it helps you think about how can you integrate each one of these learning styles into your health education or program. Because not everybody learns the same way, and you want to try to incorporate these as much as possible. I'm very much, for example, a kinesthetic learner. I also like to kind of integrate all of them. I'm visual. I like to write things down. So that's why my teaching style reflects that way, where you can do, especially in the hybrid format, you can do a lot of the reading and learning of the slides, and then in the classroom trying to apply. So kind of leaning a little bit towards kinesthetic learning, visual, and of course we discuss and talk about things. So that's why you see my interest in figuring out how do students learn best, and I tend to think that it leans towards practical application and thinking through some of these we learn about in class. Other ways of thinking about learning is understanding that there's different ways that people perceive reality and process information. So perceiving reality refers to how we understand situations. As you know, one situation can happen objectively, and you have 2 different people looking or watching, and they're going to give you a little bit of a different take on that situation. It's because we perceive things differently. So you have sensors and feelers, so they kind of immerse themselves in the situation and perceive the situation through their senses, so how it makes them feel. And then you have thinkers, those who step back, think through situations in a logical manner. So kind of taking it back, maybe putting yourself in somebody else's shoes, or trying to view it from another set of lens instead of your own. So again, you have feelers and then you have thinkers. Now when you're processing information, there are those, and this relates to how we take in information and then incorporate it into our lives. So you have watchers, so those who reflect on the information and deliberately wait to make decisions. And then you have doers, so those who act on the new information immediately and then reflect afterwards. And I can already bet that as I'm reading these out, you're thinking, oh, that's definitely me, and I'm definitely that one and not the other, because that's what I'm thinking right now. I'm definitely a thinker. I do like to step back and think through things logically. And I think I'm a watcher. So I do like to reflect on information and be deliberate about decisions. But again, as most of my answers go, it depends. So you might be a thinker and a watcher in one situation or circumstance, and you might be a feeler and doer in the other. Of course, we tend to, go towards one or the other as far as our own characteristics. But I always say it depends on the situation. But again, it's also nice to understand that the way people perceive and process information is different, and to take that into consideration as you develop education type stuff. So other types of learning styles, so imaginative learning. So it's typically people oriented and interested in finding personal connections. These are the sensors, feelers, and the watcher. Analytic learning. So this is knowledge oriented, and these individuals enjoy learning new information, processing it to a deeper understanding of how it works. So the thinker and the watcher. There's common sense learning, so skills oriented. So these individuals enjoy learning new information, how to apply it. So these are the thinkers and the doers. And then there's dynamic learning, so action oriented and interested in learning by trial and error. Now that's feeling and doing. So those are the feelers and the doers. So really interesting to kind of break down, the 2x2 of, processing and how you perceive information. And again, why it's important to know is so you can think about how does this make a difference, and how can you incorporate these different styles into different health education and health promotion. Environmental methods in health promotion. Now here we tend to think about sometimes neighborhoods, and oftentimes we think about policies and laws and how that influences our health. Policies refer to rules of an organization that has a specific purpose, whereas a law is a set of rules that a government body makes and is also enforceable and regulated on. So that's the difference between policy and law. And oftentimes we think, if I work in health promotion and I'm not, actively in law or a lawyer or an elected official, how can I help influence policies and laws? One is advocacy, getting your voice out there, being a part of a community that does advocacy. And then there's also lobbying. So direct lobbying is when you are, speaking to a specific person, for example. So you're contacting, APHA does this a lot. You'll get an email that says, contact your local official and let them know how you feel about this. So it's direct lobbying. And then grassroots lobbying, that comes from the community, and it must be directed towards a specific bill. So you're taking a position and saying, hey, this is exactly how I want people to vote, this is why it's important, and so you must reflect a specific position on a bill or legislation. So when you say, this is how I feel, this is what I think people should do, that's a call to action, and that's grassroots versus direct lobbying. And direct lobbying doesn't necessarily have to be about a specific bill, but a lot of times you lobby particular topics and causes. And I think that's it. So this is just a very basic summary, again, on social and behavioral sciences, health promotion, health education. reading deeper into your textbook. There's a lot of great examples and definitely much more constructs to learn. And I look forward to next semester or half semester, our fall 2, teaching the class of social and behavioral determinants of health, where this 30-minute mini lecture voiceover I just gave turns into 8 weeks, and we get to really dig deep into a lot of these social and behavioral influences on health, and also social determinants, which also has a piece in social justice. So I really look forward to that class. And I hope this summary at least gave you a nice sneak peek into what social and behavioral sciences is and health education and promotion. Okay, thank you. Have a good weekend.